on our call right now. So I'll go ahead and start. And so this information that we present is confidential and privileged. It is protected by HIPAA, and we should not be distributing it, copying it, or sharing it with people outside of our agency. So this one is actually the one with our current presenters. Is Paramedic Nelson or Paramedic Stafford unavailable for the entire lecture? Because we can run your case first if you guys have a time limitation. You guys can unmute or text in the chat.
This is Nick Stafford. I'm available for the entire thing, or I can go first, whatever you would
Okay.
like.
No, I'll just, if you're available for the whole, then I'll just go ahead and order. And I believe that Paramedic Nelson had also mentioned that he anticipated being available for the whole set soon. So the first case is of a 58-year-old female. EMS was called on an unresponsive party. When they arrived, she was unresponsive, in bed, if I remember correctly, and that her airway was open, but she wasn't protecting it. She had a demonstrated GCS of 3. She was diaphoretic, pale, and warm to touch. Vital signs upon arrival were obtained within the first 10 minutes, where they noticed she had a heart rate of 85, a blood pressure of 155 over 129, a respiratory rate of 8, SpO2 of 99%, and tidal of 20, and a blood glucose of 195 milligrams per deciliter. She was estimated to be about 60 kilos. The past medical history that was provided was none, as well as no previous medications, and that her husband had found her unresponsive in bed after coming home from the hospital earlier that evening. So this was like early morning. Actually, next picture, it was like 2 in the morning. He found her unresponsive, not breathing normally, and she was discharged after a workup for jaw cleaning without a diagnosis. Within the first minute of patient contact, a bag valve mask was initiated. At 4 minutes, they got the set of vital signs that I just reported to you, including her blood glucose being normal at 195 milligrams per deciliter. They found her in bed. They noticed that her pupils were equal. There was a small amount of emesis next to her face, and they prepped for DSI and hypotension, but ultimately they did not identify either of them being an issue. At 10 minutes, they started an IV. At 13 minutes, they got another set of vital signs. She has essentially no significant changes in her previous vital signs, still hypertensive at 150 by PALP. Her respiratory rate supported is 12, SATs of 99%, end tidal 7, and they documented getting a 12 lead, but it's not in ESO for me to pull up for you guys. At 16, they did document in an email summary to one of the MPD, to Dr. Mock, I believe they said that there was a lot of variability on the EKG, but I can't show that here. At 16 minutes, she was bagged with a PEEP of 5, and they gave her 16 milligrams of ketamine. At 19 minutes, they gave 90 milligrams of rocuronium. Oh, Dr. Mock's going to put the EKG in the chat. And then at 21 minutes, they intubated her with video laryngoscopy, first pass with a 7.5 ET tube. At 23 minutes, she, Dr. Mock, did you want me to take a look at the chat or talk about it at all?
No, can continue on.
Okay. At 23 minutes, she was tachycardic at 133, blood pressure of 110 over 70, respiratory at 12, SpO2 of 100, and tidal was documented as 24. At 26 minutes, she had gotten her post-intubation sedation with 16 micrograms of fentanyl based off of her weight-based dosing. And I believe at 28 minutes was supposed to indicate that transport was initiated. At 31 minutes, Another set of vital signs, heart rate 95, blood pressure 123/71, respiratory of 10, and SpO2 of 97 and tidal 31. And they gave her further post-intubation sedation with 60 milligrams of ketamine. Second IV was established, and she arrived at the hospital at 39 minutes. The Pulsera notification was that she was a red patient. The notes provided to the hospital was that husband found her unresponsive, barely breathing, recent discharge from your facility, and she's intubated. There were no vital signs reported in the Pulsera. Definitely helpful for the hospital to know what vital signs they're dealing with, if they're stable, if they potentially need to get additional agents to be ready for the patient. So that's one thing that I would, unless I missed it elsewhere. So QA discussion. I'm gonna. So, if Dr. Malkovich, all right, if I could leave you to discuss the airway areas for improvement, but if not, I can do it. So the good is that they got a rapid set of vital signs within the first 4 minutes of patient contact. Access was obtained. They checked her glucose prior to moving forward with intubation. They prepared her for all of the potential difficulties with intubation by evaluating for hypoxia as well as hypotension. They intubated her with induction and first pass. They got a 12 lead and they notified the hospital of their arrival. Areas for improvement was make sure you have a set of vital signs in your Pulsera. And then there are some areas for improvement in airway measures. Is it all right if I ask you, since you had more of a conversation with them on their email?
No, I would say no. Overall, the management is good, and I think as we raise our standard around airway management, the biggest challenge that we face is getting a full set of vital signs within the 3 minutes prior to intubation. As you see with the course of this patient, like, this patient that crashed later, just knowing where they are right as we are starting to push these medicines is critical. But that is the only place where the airway measure wasn't met. Again, there's a lot of good stuff here. I mean, there's good pre-oxygenation, but using positive pressure ventilation, all the appropriate drug dosing, post-intubation vital signs. So this is it is hard to raise our standard. It is challenging, and so that's the only area for improvement. In general, the management was good here.
Thank
And-
you. Oh, go ahead. Somebody else? No. So as for patient follow-up, in the emergency room, so this was a patient that I don't have access to view myself, so I reviewed some of the correspondences. So it's a little bit maybe brief. So CT showed a dissection with a hemopericardium. This work for you guys. Well, Dr. Mock, I see your hand raised. I can stop.
If you'd like, I can talk about the ED course.
And
And
then
if
I
you-
have this CT coronal view, and then I have ultrasound images of pre and post here. So let me know when you're ready to click on those.
Yeah, no, but I mean, the short answer is the patient crashed shortly after arrival in the emergency department. A bedside ultrasound showed a pericardial effusion with tamponade. And then it looks like you'll have the images and we can talk through what happened there.
Yeah, so this is the I believe the 4-chamber subxiphoid, but yeah, and I can just replay it while you're talking about it, like.
Yeah. So the
and
key,
point
and
to the
again,
next.
the goal here is not to not to make everyone a proficient ultrasonographer, but just to kind of understand kind of how this diagnosis presents, how it gets treated, and just to the importance of thinking through the different things that could go on with the patient. So here you're looking at the heart. The skin is up at the top, and you're going deeper into the body as you go deeper. And so here, the first thing you're seeing is the right ventricle and then the left ventricle. And it basically, it looks, as you look at the top of this, it looks almost like a man jumped on a trampoline. Like there's a lot of pressure on the right ventricle. It's not filling. And then the fluid that's outside the heart is that black stuff you see just outside. So this is
Where the arrow is.
pericardial effusion with cardiac tamponade. And at this point, the patient's blood pressure was 40 systolic.
Perfect. And then the CT here. Oh, I can't get rid of all the tabs for you guys. Let me just start over again. That doesn't look good. I'm gonna close a couple tabs and fix that. Have I get me? Okay, go ahead.
If it's easier for me to show the videos, I can do that, whatever you prefer.
Yeah, sure, that's fine. For whatever reason, my computer's not as spry today.
Okay.
So feel free.
Okay, so I'll start sharing my screen here. So
I'm gonna stop sharing the button, but
okay. So then the emergency physician performed a pericardiocentesis. So you see the needle coming down into that fluid pocket. The only it was able to withdraw, maybe like 10 to 15 milliliters of clotted blood, but pretty quickly the patient's blood pressure came back up to 100 systolic. And then I'll show the last image. So then after the pericardiocentesis, now you can see the right ventricle and the left ventricle are filling fully. There's less fluid outside the heart. So the patient's pressure improved at that point, and then she was stable enough to go to CT to make a diagnosis.
and then just for this explanation of this view, you've got the aortic arch. There's two portions of it in this image, which there shouldn't be. This represents the dissection, and then it dissects down into the aortic valve. Anything else that you want to talk to us about the transfer? And Dr. Monk?
No, so she was, the pressure was stabilized after the pericardiocentesis. So she had an ascending aortic dissection with hemopericardium. In other words, it was dissecting, and because of the dissection, the blood was filling up the pericardium. When people arrest from an ascending aortic dissection, that's typically how it happens. Is you get that blood in the pericardium. So she had a drain placed in the emergency department. She was transferred to Legacy Emmanuel Medical Center for CT surgery. Had replacement of the ascending aorta. under ECMO. She did have a cerebellar and occipital stroke. So there's some mild cognitive deficits, and she's undergoing rehab for that. But in general is recovering well.
Okay, thank you. And the abbreviation may not make, I put it in as they're plan based off of the progress note that you had sent, they're planning to remove the chest tube. And I don't know if that was just post surgical or if there was an actual problem with her lung.
Yeah, just post-surgical.
Oh, thank you. I'm only seeing the bottom left of my screen. Is that what you guys are seeing too?
Yes.
Okay. Just having all kinds of problems with this program today. It might be because of the videos that I've added to it.
Well, if it's okay, then while you're getting that set, I can just talk a little bit about why we brought this case forward.
Yeah.
One, I think it was overall an example of good airway management with those areas for improvement that I identified previously. Two, it's a relatively rare diagnosis, and this is a patient with relatively minimal risk factors. So a female in her 50s, who just has a history of hypertension. And then she presented to the emergency department with jaw pain, and had 2 negative troponins. So I think it's also to point out that emergency physicians miss stuff, and so just the fact that the patient has recently been to the emergency department, is not necessarily a clean bill of health, and this can be a really hard diagnosis to make. Is the last thing I'll say is that patients, I have missed an abdominal aortic dissection before. This is a frequently misdiagnosis because it is rare and it presents oddly. So the key things are that it's typically chest pain or belly pain plus something else, like belly pain and leg pain, chest pain and arm pain, or there can be neurologic findings. And these patients, like, they can look almost psychiatric because they look they seem so uncomfortable, but the exam is not that remarkable. And it can just it's they call acute aortic syndrome the great masquerader. So it's just a very, very humbling diagnosis and difficult to pick up.
Absolutely. I'm not sure if I present it to presentation mode, if it's going to cause problems again, but I might just stay in the slide form at this point. Yeah, so I was going to talk briefly. We talked about aortic dissections in the past, so this will be a little bit of revisiting the same stuff, but type A versus type B, depending on if you're looking at the Stanford or DeBakey. But type A's are ascending aortic aneurysms that involve the aortic arch, and they are proximal to the subclavian. Descendings are going to be, oh, go ahead, Dr. Knott.
We're not able to see your screen right now.
Okay. Can you see it now?
Yep.
Okay. I didn't even do anything. It's missing half of it right now. You can see in this on the left-hand side, there's words here, not just the picture. Unfortunately, I don't know. I think what I'm going to do is I'm going to try using my cell phone with this app, and maybe that's where it's going to work out.
Or if you want to share the presentation with me, I can present it on my screen.
Yeah, we can do that too. Just give me a sec then.
While you're doing that, I'll show the 12-lead EKG.
Okay.
So this was the initial EMS 12 lead for this patient. And that's and what you see here, as I read through this, you see this pattern of ST elevation in AVR with global depression. So appropriately, the crew did not alert for this because this pattern is typically either left main disease, because this is a sign that like the whole heart is being affected. So it's either left main disease or shock, which I think in this case was essentially shock, obstructive shock from the developing hemopericardium.
And I shared the link for presentation to your MPD.org.
You said to my email?
Yeah, the
Okay. Okay. Get that. Okay, I'm getting that up. Okay, I'll get the screen up and just tell me what to do and I'll present it.
perfect. If you want to click on case 1, and then you can click on that little blue box on the right, and then scroll forward. Perfect. Okay, so I think we'll just do this kind of, I'll skip the protocol portion of things and just talk briefly about what this portion, it's just this interest of time. So type A versus type B, as I was mentioning, involving the ascending proximal to the subclavian versus the descending, is the differences between, and the image on the right kind of indicates that it's type A versus type B criteria. The pathophysiology is usually patients that are older, that have history of hypertension, especially not well controlled. Nicotine dependence, which puts them at risk for atherosclerotic disease, so also atherosclerotic disease, regardless of nicotine use. I had read that there is some correlation with increased blood pressure, such as exertional weightlifting, as well as stimulants like cocaine and caffeine energy drink use. There's congenital predispositions such as Ehlers-Danlos and Marfan syndrome. Increased pressure associated with pregnancy or delivery can also be associated with a dissection. And then infectious or inflammatory vasculitis can also lead to dissections. Management depends on if it's going to be ascending versus descending. Descending is usually strictly medical management, and ascending aneurysms are going to be surgical. And then we work to first lower the heart rate so that they don't have rebound tachycardia, and then lower the blood pressure to try to prevent possibility for rupture. And then pain control, untreated, it's upwards of 60% of fatality. And then complications, depending on where the dissection impedes blood flow, can indicate how this patient presents. In this particular one, because of the pericardial effusion, I wrote hemorrhagic cardiac tamponade. It can be controversial to do a pericardiocentesis because it can cause rebleeding or further propagation of dissection, but clearly this patient was peri-arrest, and it obviously led to her having a better outcome and surviving surgery and still being alive and likely discharging. You can just skip out of the next 2 slides and go back to the cases.
Okay, will do. Forgive me, just one small interesting medical fact.
Yeah.
So the person who pioneered the repair for this is Michael DeBakey. Yeah, he trained at Tulane and worked in Houston for a long time. So he did the first repair of ascending aortic dissections, and then he later developed one himself, and then had the repair performed by surgeons that he trained.
That's crazy. And glad that you weren't going to say he did it himself.
No. Okay. So you're going to go to case 2?
Yeah, don't worry about it. I had hypoglycemia and the airway protocol, but there's a lot of slides there, so just skip, skip, skip. All right, case 2, I believe it's going to be paramedic Nelson. Do you mind unmuting?
Hi, can you hear me?
Yeah, I think I can hear you. Is everybody else
Yes.
able to hear?
Yes, we are.
And then
Yeah.
next slide for him. 35-year-old male is what he was called on. Go ahead.
All right. Yeah, thank you. We were called and told to stage for a potential shooting. We were looking at the notes there. It was not that far away from Peace Hospital. We were called in relatively rapidly by the PD team there, and they did a really good job of telling us, of sort of securing the entryway, telling us exactly where to go so that there was a pretty quick entry and egress from the scene. When we got there, we found the male in question lying on the sidewalk, surrounded by PD attending to them. They had already placed 2 tourniquets and a pressure dressing, indicated to me that there were 3 injuries to, 3 gunshots, bilateral femoral and upper shoulder that was injured. So they had done pretty good bleeding control prior to arrival. When I got there was no massive external hemorrhage. I didn't see any spurting blood. They said that they'd had a hard time trying to control the wound on one side. So there were 2 tourniquets, one on the upper arm, one on the lower leg, and then the other one, which was too high to tourniquet. They put the pressure dressing there. So we rapidly flipped him to make sure that there were no torso injuries, got a set of lung sounds, and then extricated him from the ground to the stretcher in the back of the ambulance and took off.
Next slide.
We had, mhm. And at that time, we also alerted the hospital to red trauma with the gunshot wounds, and then we continued en route to, like I said, it was a pretty quick transport. So most of what we did was make sure his blood pressure was stable. We got access. We were limited in our options for access to the one arm that wasn't tourniqueted. But fortunately, his blood pressure was pretty good. He was a little pale, but not too shocky. So we just started fluids wide open and gave him, I think it was 100 fentanyl for the pain, and then arrived at the hospital without any decomposition in his vital signs.
Thank you. Next slide. Marla, can you, next slide? Thank you. Thank you, Paramedic Nelson. Yeah, I thought that reviewing your guys' case, that you had minimal scene time, because of minimal scene time, didn't lead to worse outcome or lack of care to this patient. As we mentioned in communication, that you were very diligent in ensuring that when you were checking for other holes to this patient, that you maintained spinal precautions until you were able to ensure that spinal precautions were not necessary. And I thought that your documentation, all of the stuff that's in the boxes on the right, were from your documentation. So I thought that there's a lot of objective reporting.
Mhm.
Next slide. I can report this portion. It's the Pulsera. So red notification, bilateral femoral gunshot wounds, bilateral tourniquets, currently conscious, and it must have been that you activated and then put in vital signs as vital signs to follow. You noted that mildly tachycardic, not hypotensive, and respiratory rate and SpO2 are normal limits, GCS of 15. Next slide. Scene time, as mentioned before, IV access, trauma activation, physical exam and assessment were really solid. Treatment, including you documented that you had turned the heat on in the ambulance, and then difficulties with the SpO2, which may be related to, I'm not sure if there was some impediment of the extremity with the tourniquet, or I think that you also mentioned that the one extremity that was free was also getting blood pressures on it. So they're, indicating that you didn't feel that the hypoxia that was being obtained was accurate, as it was complicated by the condition of the patient. Is that correct?
Yeah, that's correct. There was a not very good pleth waveform, and I knew that, yeah, we were trying to both tourniquet it to get IV access, tourniquet to get the blood pressure. We really only had one limb to work with.
Yeah. And, you addressed it in your documentation. The only thing is that you had indicated that you'd given 200 cc's of IV fluids, and I would say if there was a hypotension and you documented GCS of 14, so maybe there was a little bit of confusion, but reminding that we're working with permissive hypotension in traumas to only give IV fluids if they're altered or they're hypotensive. And then the reason that I have hemostatic agent use here is that's kind of how this case came up, was that there was a brevity of this information being passed on to the trauma team. And that's really the only thing that I have here. Next slide. So in the emergency room, they documented that the tourniquets were placed, and I imagine that was from you, Adrian, that the tourniquets were placed at midnight 05, as that was information probably wasn't available elsewhere. And then physical exam, they noted that the right upper extremity had a tourniquet to the proximal arm with good radial pulse. There was a 3 millimeter penetrating wound to the anterior and proximal arm that was hemostatic, and a penetrating wound to the posterior portion of that same arm. The left lower extremity had some swelling. A tourniquet was placed proximal to the thigh, and that there was a penetrating wound to the anterior aspect, as well as to the medial thigh. They couldn't get a pulse, but they were able to Doppler a pulse, palpable pulse they couldn't get, but they were able to Doppler it. Right lower extremity had a dressing, that pressure dressing proximal thigh, with a penetrating wound to the medial proximal thigh. They sedated him in order to get a central line placed. They gave prophylactic antibiotics due to concern for infection risk, and then pain controlled updated tetanus. And then the CT imaging, they ended up getting CT extremities as well as a CT angio. And they noted that the right lower extremity had an occlusion proximal to the femoral artery, concern for arterial injury. And then they noted comminuted bilateral proximal femur fractures and a comminuted right humerus fracture. So I was pretty surprised based off of, it sounds like three potential penetrating wounds leading to pretty devastating injuries. Not devastating in the sense that he wouldn't survive it, but very much not just a soft tissue wound. Hospital course, he was taken to the OR. He had a right femoral internal fixation and placement of a intramedullary nail, as well as removal of foreign bodies, which ended up being the hemostatic sponges to the right hip. And then they IND'd his left femur fracture, which I don't know if they ended up putting sponges on that side. I assume that there's just IND and that the foreign body was specific to the right lower extremity sponges. And then placement of a tibial traction pin. They also cleaned out the right humerus and placed a coaptation splint for that arm. He went back to the OR on hospital day 1 for internal fixation of the left lower extremity, as well as internal fixation to his right humerus. And then during his hospitalization, he's still currently admitted based off of last night's review. He developed a left lower extremity that was cold to touch, but ultrasound and both venous and arterial phases showed no evidence of arterial impairment or thrombosis. So they're just monitoring him. Next slide. So I believe, based off of emails, that our SWAT or our tactical law enforcement colleagues are using this agent called XStat. Is that correct for anyone who knows for sure?
No, that is correct. It was authorized in 2022, but this was the first deployment. And to be clear, like, this is, we're bringing this case forward as a teaching case and as an example of like where we can grow. Like our job is to make the system work as smoothly as possible from pre-hospital care into the hospital, and so we want to increase the knowledge of this and increase our ability to communicate about this, because all of the stuff that matters in the pre-hospital care of this patient absolutely happened. Bleeding control, rapid scene time, like pre-hospital
Awesome.
care, spot on.
So its uses for smaller entrance wounds. The benefit is that it's at least off of their website, they're the only FDA approved agent for severe bleeding from penetrating narrow entrance wounds. It applies hemostatic pressure within the wound, not requiring direct pressure externally. It applies in seconds and deploys fully within 30 seconds. And then it's a syringe applicator that's easy to learn how to use. The product is sterile. I think it said that it had a shelf life of 5 years and it dispenses 38 radio opaque sponges. Can you click on the sponges, Dr. Mock? You have to use the arrow to click on it. I go back.
Okay,
And then
the word sponges. Got it. Okay.
Are you in presentation mode? Okay, perfect.
And
And then can you pause?
Mhm.
And then can you go to 1 minute? I believe it is right at 1 minute that it gets rid of the unnecessary talk.
Okay.
I'll go a little further. A little further until you see the inventor guy. I'll tell you when I can see it. Keep on going. There. Just
There.
maybe 1 minute 20, just where he starts talking. Oh, never mind. 1 minute 30 sounds great. And then you can play if you don't mind.
Cool. For centuries, everybody's used gauze to stop bleeding. You know, back to the earliest times, you pack material into a wound and attempt to put pressure on it. John Steinbaugh is a former special
Just online. Can everyone hear the audio for this?
I can.
Jackie, you said you can.
I can.
forces medic who served for more than 20 years in the Army. He was on the front lines in Iraq when calls for better equipment started going up the chain of command. Back in 2006, 2007, height of the war, medics were getting fed up with the standard gauze. We started seeing wounds that were much worse than what we were seeing at the beginning of the war. Medics were having more difficulty stopping the bleeding. The way medics described the device they wanted was fix a flat. So you think of your tire, you inject a fix a flat in your tire, it finds the escaping air, it plugs it, and done. So Steinbaugh and a team of experts from the military and private sector got to work. Early ideas like inserting foam or gel into the wounds didn't sufficiently stop the bleeding, but soon they stumbled on something that did work. We literally went to Williams Sonoma, bought compressed sponges out of the kitchen store, loaded them in homemade syringes that we made, and put them in a model, and they expanded and worked. Steinbaugh retired from the military and joined Rev Medics, the private medical device company taking the lead on the product's development. There, Steinbaugh and his colleagues spent 3 years refining the device with the help of a $5 million grant from the U.S. Army. And earlier this year, following FDA approval, the company launched the product, now called the XStat. Steinbaugh gave us a demo recently in the company lab. So on the battlefield at the point of injury, the medic will come up to a casualty. They'll assess the casualty. He will pull out the device, lock the handle. He will inject the syringe into the wound close to the artery, and then he will press the plunger and rapidly apply the XStat to the wound. Because the sponges are compressed, once they make contact with blood, they expand 15 times their size. They fill the cavity and put pressure on the walls of the cavity to be able to stop the bleeding without having to apply pressure. Well, the XStat has yet to be used on an injured human. This is a photograph.
So it has been used at least in Clark County. And it dispenses 38 radio opaque sponges that show up on imaging studies. And they have to be removed. They don't disintegrate. So they have to, so the surgeons need to know about it in order to remove them, as we don't want to leave any foreign bodies that will not absorb and potentially be a nidus for infection. And then just push our arrow to the right. There'll be a picture of the sponges. Yeah, perfect. And then arrow next. So I just brought up our hemorrhage control protocol, external bleeding, controlling of direct pressure. If that's not appropriate or not adequate to control, then using commercially available items such as a tourniquet, and make sure that we date and time the tourniquet and do not remove it until we arrive to the hospital to ensure that we don't take it down to see if it's still needed and mess around with it. Utilize improvised tourniquets only if commercially designed tourniquets are unavailable, and remove and replace improvised tourniquets as time allows. If direct pressure and tourniquet application is ineffective or impractical, junctional binding or pressure dressing would be appropriate, including wound packing. And then if necessary to address amputation, go to amputation protocol. And if necessary to address shock, go to shock protocol. The only thing I think I would add to this, that's not in the protocol, and I don't think it needs to be, but is the common sense consideration of removing any jewelry distally to the affected limb, especially if you're placing a tourniquet. Next slide. Obviously, it's not the highest priority, but more of a if you have time to allow to ensure that this doesn't end up being an issue removing later. Next slide. All right, and then you should go next slide, and it should go to case 3.
Will do. And I just wanted to say thanks to Paramedic Nelson for presenting. I really appreciate you being willing to be here and do that. And then the only other thing that I would say about this case is, ideally, if this agent is deployed by law enforcement, ideally, bring the container, or just clarify, law enforcement should be giving you the information about what was used, and then we want to pass that on to the hospital. I mean, these are rarely used. Again, first application in Clark County since 2022, and really only applicable for junctional penetrating wounds.
Absolutely. And, now that I can see that it's a one-time use applicator syringe, I'm not sure, I guess, ideally bring it in, but if they end up tossing it in the mix of things, just make sure that you make every effort to get that information to the hospital. And if it's not immediately available after you drop off the patient and you find out later, please let us know.
Yeah, thank you.
Yeah, and thank you, Paramedic Nelson, for presenting. Next slide.
Thank you.
Paramedic Stafford.
Yes. Hello. Good morning.
Good morning. Thank you. Thanks for also joining our county as a newer guy to our county.
Well, thank you.
Yeah. Next slide. So if you were dispatched to a 1 month and 13-day-old, is that correct?
Yeah, this was a 5-week-old dispatch for difficulty breathing. The report that we got was that family had been sick for a couple days and that he had been fussy for 24 hours and then quote unquote off, just sort of acting a little bit strange for 6 hours. Mom reported that the way he was acting when we found him was the same that he had been for 6 hours. It wasn't quite clear why they hadn't called earlier, but it seemed like there hadn't been a change in his presentation. I think they had just talked to an advice nurse who had recommended that they call 911. So fire had arrived before we did. They had put him on oxygen just due to his belly breathing.
Next slide.
But his lungs were clear. He was mottled. Let's see, what else can we tell just from the initial presentation? He had still his full clothes on, so to get him kind of out of people's arms and put on EKG to get an initial set of vitals took a minute. We found him with a heart rate in the 240s, I believe. Like I said, the skin was mottled and central mottled, but he didn't have, I guess, the cap refill that I would have thought would have gone with that. I think it was like maybe 3 seconds, 2 to 3 seconds. And then his fontanelle was not particularly depressed. I have a 1-year-old, and I remember when she was that age, and so I was kind of comparing the fontanelles. They're roughly similar. So, and then his skin was red. We'd put a tourniquet on to try and get an IV, and it was just definitely red. So I guess the picture was just not quite. I just assumed that he was septic given his age and the sickness in the house. But yeah, with the clear lungs and him not looking as, I guess, dehydrated as I would have imagined given his modeling, I think the picture was just a little less clear. So we were fairly rural, long, steep driveway with no turnaround. So getting cars moved and fire rigs moved and the ambulance turnaround took a minute. So we were on scene longer than I would have liked. I think it was just over 20 minutes. And in that time, we figured out that his sugar was a little bit too low at 30. And then obviously we had the heart rate. So trouble getting a SAT on him. I think I included one SAT in the chart that had come through when the monitor transmitted data at 93, but I don't know how accurate that was. We tried all the different devices in all the different locations that we could find and just did not get good data on that. So excuse the lack of good vitals there. I called up here. Fire is BLS. We don't have paramedic firefighters, so I called for our paramedic battalion chief to ride in with us. And then I am not super familiar with sick kids, so I figured just given his kind of abnormal presentation, to go along with all this, he was responding maybe a little slower than I would have liked, but very vigorous. He was grabbing my hand as we were assessing him and looking at me. So certainly not unresponsive in any way. Just obviously sick. So the presentation was a little less clear than I would have liked. So we gave you a call just to run it by you and just kind of get a second set of eyes, ALS eyes, as it were, just to take a look at this and see, how aggressive do we think we ought to be with this? Should we drill and do fluid boluses? Obviously, we can treat his hypoglycemia that way. And then do we want to worry about airway management? We don't have great vitals on him, and but he's obviously having trouble breathing. I guess for me, I don't know if intubating him and getting him really well oxygenated that way in a way that we can guarantee is the best course of action. So I guess there were a lot of questions in my head. So I figured I would just give you a call and run it by you just to see what your thoughts were. So that's what we did.
And I'll say that you contacted online medical control. I answered the phone. You had painted the picture of this very young child, not under a month, but almost under a month, who was concerned for infectious process, who IV access was a difficulty. You got a low glucose, an unreliable SpO2, but you can tell that the patient is working hard to breathe, but his breath sounds are clear. And the questions were, should we go ahead and drill this kid at this point? And should we manage his airway, as I don't think he's getting better, but I don't think that he is in respiratory arrest at this time. So we had talked through those portions, my recollection.
Exactly. And at that point, I think we had been down the road. We'd been on scene for 20 some odd minutes and transporting for an additional, I don't know, at that point, probably 10, 15 minutes. So as we're finishing our conversation, that's when the battalion chief met up with us. And I think his mentation had started to change kind of as that conversation finished. And so it became more obvious the direction that he was going to take, which in some ways was clarifying. So yeah, coupled with the conversation that you and I had, I think it became clear where he needed to go treatment wise. And he started to kind of show himself, which had been a little less clear before that. So that's what we did.
And I would just add one more thing, is that we had talked about at what point should you move forward with RSIing this kid? And at this point, he seemed to be responding to the supplemental oxygen. And because I remember, I thought that there was like a blow by. I don't see it on here on the, and 10-liter non-rebreather. He seemed to be responding, not getting worse, is the way that we had described that. For those who are wondering, well, why didn't you RSI?
Yeah, I think for me, it's if he's breathing on his own. I mean, to me, I just figured he was acidotic with the sepsis, and I, especially with all this chat that we've been having about resuscitating before we intubate, Yeah, I guess I really worry about killing him on intubation, given his acidosis. If he stops breathing, and our ability to kind of match his respirations without hurting his lungs, I think are limited. Our ventilator doesn't work in kids that small, so we're going to be doing this manually if we bag him. And I worry we're going to cause more harm than good if he hasn't forced our hand. But then, of course, the other side of that is if we don't intubate him and it becomes hypoxic, then he has an issue there. So it wasn't clear to me what we should do, and that was part of the reason for the phone call to you.
Yep.
Was
And then
trying to see kind of the
for those
balance
that,
we
oh, go ahead.
pursue.
Sorry, go ahead.
Nope, all you.
No, I was just going to say, for those that don't know what normal range vital signs for this age child is he's tachycardic. His upper limits of normal should be 190, and his tachypnea is only minimal. Upper limits of normal is 53, based off of my pediatric reference guide. So what we're dealing with is skin changes that are abnormal with a delayed cap refill, tachycardia, and a mental status that isn't what we'd expect it to be. So that's all I was just more getting at.
Exactly. So we ended up giving him a fluid challenge and glucose, and then we were able to remeasure that. So we fixed the numbers, I will say. His heart rate responded well to that and went to normal. Pediatric range for ours, I think, was 125. So he's right in there for heart rate, and then sugar, slightly hyperglycemic, but we'll call that we fixed the sugar. And his mental status actually declined fairly suddenly at that point. So by the time we arrived at Salmon Creek, this had all kind of coalesced, and he was responding to physical stimuli, not pain, but definitely physical stimuli, and still crying, but clearly a downward trend. And at that point, it was clear that he was going to get intubated, since we had fixed the vitals, and the mentation was not responding well to that.
And I will say that you also updated the hospital about the need for potential airway intubation.
Yeah, and my apologies for not doing a pulsar. We called a radio report on this one so we could give them a direct kind of heads up.
Thank you very much for your description of what happened. It's definitely a very critically ill kid, and one kid that nobody wants to spend 61 minutes with in the back of an ambulance. So thank you very much for presenting and for describing your decision making and your care. Next slide. So as mentioned, is radio report, great. So just reviewing this case, I really thought there was a lot of really well thought out, even if there hasn't been a lot of previous pediatric resuscitation cases, for anybody, but particularly new to our county. I thought your index of suspicion was right on. You did a primary survey, you did early vital signs, you documented that the patient was full term, no complications, no past medical history. So you obtained that. You got presenting illness and history that was pertinent with his mom being sick preceding that. You asked for additional help, both by asking for a third rider and reaching out to online medical control. Decision to monitor respiratory status closely, as opposed to doing every procedure we have in our toolbox, which would be moving forward to aggressive intubation, managing hypoglycemia, sepsis management. You had indicated to me on the phone, but also in your documentation, that you calculated what an IV fluid bolus would be for this kid and was mindful about including the amount of dextrose that you gave to the kid as combined as IV fluid bolus for him to not over resuscitate him. And then you notified the hospital of any of the update that you were coming to them, but also concern for sepsis and concern for venting airway management. And then you documented his response to treatment that you provided. The only thing, and I think we talked about this, is maybe moving to an IO earlier after multiple failed peripheral attempts. But I think that it can be a struggle sometimes when we're like, oh, we'll want to do a peripheral IV. That's not too much of like a lot of concern, but then going towards IO, it seems, more invasive, especially in an awake patient. But I think that this patient definitely, as in the moment, seemed it would be appropriate to place an IO, and then after the fact, definitely was appropriate to place an IO. Next slide.
Yeah, I think I don't place conscious IOs with any frequency, and I certainly don't do it in kids. So it's definitely apprehensive to do it while he was so responsive, and then as he became less so, I think the decision gets a little bit easier. So I'd like to think that next time I'll move a little quicker.
No, I mean, I don't think that there was any significant detriment based off of the care and the timeline that you had with that patient. So next slide.
And if I could,
yeah.
I agree completely with the decision to resuscitate this baby before you consider advanced airway management. And remember that, you have steps between giving giving oxygen to a non-rebreather and an intubation. I mean, you bag valve mask. I know sounds like in this case you're relatively short on hands in the back. You can use a supraglottic airway in a patient like this, but giving this patient a period of apnea before you fully resuscitated them, I think is really high risk. And particularly in pediatrics, we can typically bag or use a supraglottic airway to improve their oxygenation. And then certainly if we've resuscitated and hit those other goals and you want to move to an endotracheal tube, that makes sense. But I think just remember there are other options for positive pressure.
And I think in this particular case specifically, you've got a kid who's altered, who looks like they're in respiratory distress with poor perfusion, but you've got clear lung sounds. So you've got mom who might have a flu-like illness, but I think that really speaks to there's potential metabolic cause for this kid's respiratory distress. And that means that, we really want to we don't really quite trust the SpO2. We think it's 93%, but far as you can tell, your kid's not actually hypoxic. And without abnormal respiratory findings, I would be more worried about a metabolic cause causing this kid to be as sick as he was, or a cardiac cause. But anyways, it's just my 2 cents. Go ahead.
No, agreed.
So in the emergency room, he arrived with a heart rate of 123, a respiratory rate of 40, and an SpO2 of 100%. And this actually was mentioned by paramedic Stafford when I asked for a temp. He had a 94 degrees Fahrenheit. And so we had talked about that low and high can also be indicators for sepsis. So his rectal temp was 90 degrees. His initial labs showed that he was quite acidotic at 6.86, remembering normal range is usually around 7.4. His CO2 was 32 and his white count was pretty elevated at 26,000. His lactate was very elevated as well, speaking to his perfusion mismatch, and his liver enzymes were elevated. For unknown reasons, his ammonia level was high. And then he also had an elevated heart enzyme and elevated heart failure lab as well. So they placed him on CPAP at 5 with a respirators of 21 and a FiO2 of 100. They consulted Randall's. This was a patient brought to Legacy. I don't know if you are aware of him from your colleagues, Dr. Mock.
I hadn't had a conversation with the doc that treated him yet.
And then they spoke to Randall's. They said don't intubate him until the epi infusion was running for a while, because they were concerned that with how severely acidotic he was, that he would go into cardiac arrest with intubation. So approximately, I think just shy of an hour after resuscitation, they did intubate successfully with atropine, etomidate, and rock with a 3.0 ET tube on the second pass. So that kind of speaks to that might have been a little bit more of a difficult airway, especially in the back of an ambulance. And also given the fact that he was so acidotic, the outcome could have been a lot poorer prior to resuscitation. They gave him alloprostale, which is concerns that he had a patent ductus arteriosus that might have led him to cardiogenic shock given his elevated heart enzyme and his heart failure lab. They had him on an epi drip. They treated him with antibiotics. They gave him another IV fluid bolus. They gave him hydrocortisone in case that there was a metabolic issue that was contributing to his state. And because of how acidotic he was, he also got bicarb. He got transferred to Randall's in cardiogenic shock with LV failure. He was in respiratory failure with hypoxia, and he had underwent disseminated intravascular coagulopathy, or DIC. He had acute kidney injury and an unknown reason for this elevated ammonia. During his hospitalization, he received blood products in the form of plasma, cryoprecipitate, and then he also got blood. And they broadened his antibiotics to include acyclovir in the event that he had meningitis. They thought that his cardiogenic shock was secondary to his disease state. He was found to be enterovirus positive. And I will say the ER doc's note stated that they saw mom vomiting in the background. So she was actively sick as well. And then hospital day 3, he was extubated. They performed an LP. The LP was unremarkable. Last I checked, he's still admitted, doing better, no longer in heart failure. And they think that he has a congenital metabolic problem that contributed to how sick he got with this viral illness, but not confirmed at this point. Next slide. Or any questions or concerns or thoughts?
No, and that's probably why the ammonia is high, is some underlying metabolic problem that this virus revealed.
Mm-hmm. So I just thought I'd talk briefly about PEDS respiratory failure. It's when a pediatric's respiratory effort is inadequate, prohibiting adequate gas exchange in the form of O2 and CO2 transfer. And then children are more vulnerable. They're more vulnerable for a couple of reasons. One of them being respiratory drive. That respiratory drive isn't fully formulated until after, just probably from what I was reading, a couple days to up to a week after birth. So premature babies are really important to determine because the ability to compensate is lower for a number of reasons, including the respiratory drive and then airway anatomy. The airway resistance is higher with kids' anatomy because of the airway radius. The airway resistance is inversely proportional. So any kind of nasal secretions or obstructions are more detrimental in pediatrics than in adults. And then their airway anatomy, such as their pharynx, their hypopharynx, and their trachea, are more collapsible, so it increases their potential for respiratory failure. And then there are less alveoli in general in pediatrics than adults comparatively. So all of these make them more vulnerable. In addition to the other portion is that their ribs are more horizontal, so it is more of an inefficient respiratory efforts, and they fatigue out more frequently, as we have talked about in previous discussions, that kids do okay until they don't. One of the most prominent causes of cardiac arrest is respiratory failure. So really identifying when a kid is having a difficulty in gas exchange and making sure you support them prior to them deteriorating to a cardiac arrest. And then critical findings, you're going to see rapid heart rates, labored heart rates, abnormal breathing patterns, changes in alertness, or abnormal findings in your SpO2 or end-tidal CO2. Next, or arrow to the right, which will magnify that picture. This talks about the main causes of respiratory failure in children. So infection, laryngeal malacia, foreign bodies, anaphylaxis, involving the upper airways. And then they further break this down to lower airway obstruction, restrictive lung disease, such as pneumonia, edema, effusions, and respiratory distress syndrome, as well as central nervous system disorders, which can be medication-related, metabolic or infection encephalopathy, or intracranial injury, and then peripheral causes of the nervous system. Next slide. Next slide. So our protocol for PEDS distress, respiratory distress, looking for upper airway causes, such as stridor and manage it, or croup and managing it, or anaphylaxis and managing it, asthma as another consideration. And then under the C portion, insufficient respiration or respiratory arrest, real obstruction, ventilate with a bag valve mask. If you think an opioid is in play, you can try Narcan. Next slide. And then kids under 2 years of age, they can have acute bronchiolitis, where they can have mild to moderate respiratory distress. We're going to be starting least invasive with blow-by or nasal cannula, and then escalating to more such as mask monitoring for SpO2 and end tidal, and maintaining SATs of greater than 92%. If the child is wheezy, they could trial of albuterol or leave albuterol if we don't have albuterol. And if they're in severe respiratory distress and they have wheezes, albuterol or leave albuterol, and prepare for positive ventilation. As Dr. Mock had mentioned, that we have some tools between bag valve mask and intubation. Um, uh, and then end tidal should be prepare for intubation if they're apneic or end tidals climbing greater than 55 or unable to maintain SATs above 85. Next slide. And then aggressive airway management is appropriate for the pediatric patient who does not respond to treatment or is rapidly deteriorating, which sounds like in paramedic Stafford's situation that was approaching. Hyperventilation may be a response to an underlying medical problem and should only be considered after these other causes have been excluded. Do not treat hyperventilation by rebreathing CO2. So never place them on a mask to rebreathe without oxygen. And CAPNO and monitoring CAPNO. All right, next slide. Next slide.
Oh, and if I could, I just wanted to say, one, Nick, thanks for presenting, and two, just great job taking care of a super sick kid. I think this is a really challenging age. I mean, we see a chunk of neonates, and then, kids, once they get past 2 months, kind of start to look similar, but like in that, like 1 month to 2 month range, like it's pretty rare to get a kid that's that sick in that range. And so I just appreciate all the thought that went into this, all the careful resuscitation, getting online medical control involved. And I mean, the decision not to intubate this kid is crucial. So I just think this is a really, really well-run case.
I second that. Next slide. I apologize for going over. I'm going to blame it for technical difficulties and Dr. Mock saving me. But summary here is that we have a hemostatic agent that our tactical law enforcement colleagues might be using called XStat. It's sponges. Make sure that the hospital knows that they've been deployed. They need to be removed as well. And then aortic dissections, they can involve the upper portion or the lower portion of the aorta. Upper portion can put a patient at risk for having a pericardial effusion. They can also occlude the coronary arteries, so they can look like a STEMI, so they definitely can manifest like a cardiac patient. And then sick pediatrics that I think my learning point for you guys there would be sick pediatrics that have mottled skin and increased respiratory effort. Make sure you resuscitate adequately before moving forward to escalating airway management, as this patient may be sicker metabolically than we know, and moving forward without resuscitation can lead to bad outcomes. So next slide. Come check out the cherry blossoms wherever they are near you guys. If you have any questions, feel free to ask now or email. Next slide. And please give us feedback about, and one more, next slide. Please give us feedback about our cases and our lectures to you guys. I apologize that there was technical difficulties with the program that I used today, but I've used it for 5 years and it's just been the only time it's happened, but definitely will contact them to improve future experiences. And if you have any cases that you'd like to have me present, send them to me. I have a small list of cases that others have referred, and I would want to thank everybody, Nick and Adrian, for presenting their cases today. Daryl was going to, but he's out of, I guess, the county. So it really is helpful to get your guys' perspective and your guys' description of what was going on. So thank you.
No, I second that. Becky, thanks for presenting. Appreciate it. I'll paste this link into the chat as well.
I'm all done unless anybody has any questions.
Thank you.
Thanks.